Hey everyone, this is the pre-class recording for the immune system, part 2. So you remember last class period we said there were 4 functions of the immune system, and we had already talked about cancer surveillance during the cell part 2, and last class period we talked about immunity. So this class period we're going to focus on differentiating between self versus non-self and inflammation. So, identifying self versus non-self. If you look at this particular slide, it makes it look like the process is pretty simple. You just have white blood cells that are looking at all the other cells that it passes to see if it has a self marker or a foreign antigen marker, and if it's got a foreign antigen marker, it gets rid of it. So the concept behind this process is pretty simple, but when you start looking at all the little steps, it actually is pretty complicated. So what I'm presenting today is simplified quite a bit. If you're interested in this topic and you want all the detail, it's all there in your book. But for the rest of you, let's make it as simple as we can. Okay, our goal here is to have what we call self-tolerance. In other words, we want our immune system to tolerate our self cells. We don't want there to be an immune response directed at our own cells and our own antigens. If the immune system decides to attack a self-antigen, what do we call that? Right, we call that an autoimmune disease. Okay, so what we want is we want to have self-tolerance instead of autoimmune disease. And you actually have 3 mechanisms in place to try and achieve self-tolerance. The first 2 are things that we've already kind of referred to as we've talked about the immune system. The first one, of course, is through the activity of the regulatory T cells. Now, if you remember our discussion about the regulatory T cell, we said that it had 2 jobs, right? The first job was to shut off the immune response once we've already gotten rid of the pathogen. The second job was to suppress the activity of any potentially self-reactive white blood cells that it may find. So here in this little slide, you see the regulatory T cells found some potentially self-reactive cells, meaning cells that might go out and attack self cells. So it's stopping them. It's going to get rid of those cells before it can engage in any autoimmune activity. So that's the first mechanism you have in place for self-tolerance. The second one is through the activity of the bone marrow and the thymus. Remember we said that the T cells mature in the thymus and the B cells mature in the bone marrow. And while those baby white blood cells are still in the bone marrow and the bone marrow and the thymus are supposed to be screening them to see if it finds any that are potentially self-reactive. And if it finds them, it's supposed to get rid of those self-reactive cells before they ever release them into the general circulation. So that's the second way that your immune system provides you with self-tolerance. But the most important way that you have self-tolerance is through the activity of what we call major histocompatibility complex molecules, or MHC molecules. MHC molecules are commonly referred to as self-recognition proteins. So basically what the MHC molecule is a protein that you're going to find on the surface of almost every cell in the body. And its job is to display antigens for the T cells to inspect. So the MHC molecule is where the T cells look to see if there's any foreign antigen out there that it needs to generate an immune response against. Okay, do you see that black rectangle that's on the cell membrane of the phagocytic cell? That is an MHC molecule, and it's displaying a foreign antigen for the T cell to look at. Okay, so the T cells look at the MHC molecules to see if there's a foreign antigen displayed on it. And if it sees a foreign antigen displayed on the MHC molecule, that T cell is going to generate an immune response. If there is no foreign antigen being displayed on an MHC, then the T cell does nothing. Okay, so bottom line, normal cells should not be displaying foreign antigens, so that should not trigger an immune response. So only cells that have been infected or that are abnormal in some way should be targeted for immune response. Okay, now, there are actually two kinds of MHC molecules, class 1 and class 2. The two different classes are found on different kinds of cells, and they display different kinds of antigens. They work with different T cells. Okay, so those are the three things that I want you to notice that are the differences between class 1 and class 2 MHCs as we go through the discussion. They are found on different kinds of cells, they display different kinds of antigens, and they work with different kinds of T cells. Okay, so let's talk about the differences between the class 1 and the class 2 MHC molecule. I actually want to talk about the class 2 MHC first because it actually starts to work first when a pathogen enters the body. Okay, so let's talk about the class 2 MHC molecule. The MHC that you see in this particular slide is a class 2. Class 2 MHC molecules are found mostly on phagocytic cells. Okay, they're found on antigen-presenting cells. Remember, when we looked at this particular picture before, we said this was an antigen-presenting cell. It was presenting a foreign antigen to the T cell. Okay, so the class 2 MHC molecules are found on antigen-presenting cells. And since antigen-presenting cells are phagocytic cells, that means there's all kinds of foreign antigens that you might find displayed on a class 2, because anything that this phagocytic cell phagocytizes could be potentially displayed on that cell's class 2 MHC molecule. So there's all kinds of strange foreign antigens that you might see displayed on a class 2 MHC. Now, the class 2 MHC molecules work with the helper T cells. So in this particular slide, you see that that's a helper T cell that the antigen-presenting cell is showing its foreign antigen to. Helper T cells look at the class 2 MHC molecule of every phagocytic cell that it passes. And if it sees a foreign antigen being displayed on that class 2 MHC molecule, that's going to activate the helper T cell. And then the helper T cell is going to go and activate the B cells and the other kinds of T cells and get the whole business of adaptive immunity going. Okay, but here's the interesting thing. The helper T cell must see its particular foreign antigen being displayed on a class 2 MHC molecule, or it will do nothing. Okay, so in other words, if a foreign antigen is present and the helper T cell sees it, but that antigen is not being displayed on a class 2 MHC molecule, that helper T cell will do nothing. Okay, and that, we think, is sort of like a protective mechanism to make sure that the helper T cell does not activate accidentally or by mistake. Okay, so the helper T cell has to see its foreign antigen being displayed on a class 2 MHC molecule, or it will do nothing. If it sees its foreign antigen being displayed on an MHC molecule, then that helper T will activate and get the rest of adaptive immunity going. Okay, so that was all about the class 2 MHC. Let's look at the class 1 and see how it's different from the class 2. Okay, now we said that the class 2 MHC was found on antigen-presenting cells, and since those cells were capable of phagocytosis, there was no limit to what kinds of weird antigens you might find being displayed on a class 2. But the class 1 MHC molecules are found on almost every other cell in your body. And since all those other cells are not capable of phagocytosis, then there's a limit to the kinds of antigens that you might find displayed on a class 1. Okay, class 1 MHC molecules are only going to display antigens that are already inside the cell. Okay, so you might find maybe a normal self-antigen being displayed on a class 1. Or you might find an abnormal cancer antigen being displayed on that class 1. Probably the only other thing you're going to find on a class 1 would be a viral antigen. Because you remember the way viruses replicate? They have to go inside your cell and they use your cell's machinery to reproduce themselves. Okay, so once the virus enters your cell, the antigen might be displayed on the class 1 MHC molecule. Now, sometimes bacteria will go inside your cell too. They don't have to though, because the bacteria can multiply on their own outside of your cell without having to go inside. But the viruses have to go inside. So you're much more likely to find a viral antigen being displayed on a class 1 MHC than a bacterial antigen. All right, now if you look at the slide, you see the other way that the two classes are different is, remember we said the class 2 MHC works with the helper T cell. Well, the class 1 MHC works with the cytotoxic T cell. So the class 1 MHC molecule is where the cytotoxic T cell will look to see if there's a foreign antigen out there that it needs to get rid of and generate an immune response. If the cytotoxic T cell finds an abnormal antigen on a class 1 MHC molecule, it will target that cell for destruction. Okay, but again, that cytotoxic T cell has to see its particular foreign antigen being displayed on a class 1 MHC molecule, or it will do nothing. Okay, so if it sees its foreign antigen, but it is not being displayed on a class 1 MHC molecule, that cytotoxic T cell will do nothing. It has to see that foreign antigen being displayed on a class 1 MHC molecule, or it does nothing. And again, that's probably a protective mechanism to make sure that the cytotoxic T cell doesn't start attacking things accidentally. Okay, to make sure that the cytotoxic T cell only attacks the things that need to be gotten rid of. So you see in this picture where the red arrow is, okay? That red arrow is pointing at the class 1 MHC molecule on a particular cell. And so you see the cytotoxic T cell is looking at that class 1 MHC molecule to see if there's a foreign antigen on there that it needs to get rid of. And it does see a foreign antigen there, and so it's going to release cytokines that are going to destroy that cell that has the foreign antigen on it. So that cell is a virus-infected cell that's displaying a viral antigen, so that T cell is targeting that cell for destruction. Okay, let's walk through the process from the beginning so we can see how all the steps fit together. Okay, so you see the red arrows pointing to an antigen-presenting cell, a phagocytic cell, and the little green things there are viral antigens, so that phagocytic cell is going to engulf that foreign antigen and display it on its class 2 MHC molecule. So there you see the red arrows now pointing at the antigen-presenting cell displaying the viral antigen that it phagocytized to a helper T cell. And that's going to activate the helper T cell. So the helper T cell is now going to activate the B cells. And you remember the B cells are the cells that make antibodies. So that B cell, now that it's activated, is going to start producing antibodies against that viral antigen. But of course, the helper T cell, in addition to activating the B cell, is going to start activating the cytotoxic T cells. So here you see the cytotoxic T cell that has been activated by the helper T cell. And now the cytotoxic T cell is going to go around, and every cell it passes, it's going to look at that cell's class 1 MHC molecule to see if it's displaying its particular foreign antigen that it's been programmed to get rid of. And if it sees it, like there. Now it knows that cell is infected with that particular viral antigen. It's going to target that cell for destruction. It's going to release cytokines that are going to kill that cell. So in that way, we hope to get rid of all the virus-infected cells and to clear that viral infection. Okay, this is just a little memory trick kind of thing that I saw on Google that I thought might be helpful to some of you. Just kind of a way to help you remember which MHC molecule works with which kind of T cell. So they're kind of, doing multiplication here. 4 times 2 equals 8, 8 times 1 equals 8. So that reminds you that the CD4 cell, which is the helper T cell, works with the class 2 MHC molecule. And the CD8 cell, which is the cytotoxic T cell, works with the class 1 MHC molecule. So you just match up the helper T, you match up the T cells and the MHC molecules with whichever partner gives you the product of 8. And I guess the CDs in that picture are there to, the CD4 and the CD8 to remind you of that. Whatever. If you like that little memory trick, you can use it. But the bottom line is the way that the T cells work with the MHC molecules is designed to protect your normal, non-infected, non-cancerous self cells, right? Because if your normal, non-infected, non-cancerous cells, those should not be displaying foreign antigens. And if they're not displaying foreign antigens on their MHC molecules, then they should not be stimulating any immune attack by the T cells. So in that way, we kind of avoid the autoimmune disease. Okay, I had one last little factoid that I wanted to share with you about the MHC molecule, and that is that each person has a unique set of MHC molecule genes. Okay, now the MHC molecule is actually a really big, complicated molecule. Okay, it's so big and complicated that it takes more than one gene to code the instructions for how to make it. As a matter of fact, it's so big and complicated that it takes 128 different genes in order to have the code for how to make an MHC molecule. Okay, and each of those 128 genes has many different alleles. Okay, remember alleles were like the different gene possibilities that you could have. Now, if we were talking about eye color, there's only so many different alleles that you have for eye colors. You can have brown, you can have blue, you can have hazel, you can have green. There's only so many different eye colors out there. Okay, but for the MHC genes, there are many different alleles for each gene, okay? The source that I looked at said that there could be between 50 to 650 different alleles for each of the MHC molecule genes. And remember, there are 128 different genes. So if you've got 128 different genes and each of those has between 50 to 650 alleles for each gene, you can see how it'd be almost impossible for any two people to have the exact same MHC molecule genotype unless they're identical twins. Because there's so many different possible combinations, really you can't have the same genotype unless you're identical twins. Now, that has nothing to do with how efficient the MHC molecules work. Right? Just like it doesn't really matter what eye color you have as far as your visual acuity, right? Brown eyes see just as well as blue eyes, which see just as well as hazel eyes. So when you're looking at the different MHC genotypes, that has no effect on how efficient or how effectively those MHC molecules end up working. Okay, but it does mean that we can kind of tell the difference between DNA that came from one person and DNA that came from another person if we look at the MHC molecule genes, because they're so different from person to person. So that is what we look at when we're doing tissue typing for transplants. Okay, so if we want to see it, is this person's tissue similar enough to the patient's so that the patient will not reject that donated kidney. Okay, the one place that we can look is we can look at the MHC molecule genes to see how close they are. Okay, this is also where we look when we do a lot of forensic exams. You know, sometimes they test tissue that they found under the fingernails of a murder victim because they figure that the person must have clawed the murderer before they died. And so now we're testing the tissue to see if it matches with the person that we arrested for the crime, to see if it matches up and if that could possibly be the murderer. So what we're doing is we're looking at the DNA, that part of the DNA that has the instructions for how to make MHC molecules. This is also what we look at when we're doing paternity evaluations to see if the baby's DNA is similar enough to that guy's DNA that maybe that guy is the baby's father. Okay? What we're doing is we're looking at the MHC genes to see how similar they are. Now, in the past, when you've heard people talking in the newspapers or whatever about this kind of DNA testing, a lot of times they call it HLA testing. HLA stands for human leukocyte antigen, and it's the old terminology for MHC. Okay, we probably called it, HLA stands for human leukocyte antigen. Probably we called it that because we first identified those genes on the part of the DNA where we're looking at white blood cells. Okay, but the more up-to-date term is MHC, although sometimes in the news you still hear them refer to HLA testing. But this is what they're talking about. They're looking at the part of the DNA that has the instructions for how to make MHC molecules. Okay. Now that we've talked about the role of the MHC molecule in providing you with self-tolerance and preventing your immune system from attacking self cells, let's talk about why that might happen anyway. So if your immune system is attacking self cells, we call that an autoimmune disease. And if you break down the word autoimmune, you can figure out what it means, right? Auto means self, right? Something that's automatic runs by itself. An automobile is a vehicle that runs by itself. It doesn't need horses to pull it. So auto means self, and autoimmune means the immune system's attacking self cells. Now, if your immune system is attacking self cells, those self cells are going to get injured. And now we're looking at some organ or some body system that is not going to be working properly. Now, truthfully, we don't really know why autoimmune diseases happen. We don't really know why the immune system will sometimes turn around and start attacking self cells. But we do have a lot of theories, and I'm going to describe some of them for you to think about. First of all, since we know the immune system knows what the self-antigens are supposed to look like and recognizes them by their molecular shapes, that if a self-antigen gets damaged somehow, maybe it now looks different and the immune system doesn't recognize it anymore. Maybe the self-antigens get damaged because of an infection or because of inflammation. Or maybe a self-antigen gets complex to a drug or a chemical that the person is exposed to. And now it doesn't look the same and the immune system doesn't recognize it and starts to attack it. So that's one possibility for how autoimmune diseases might get started. Another theory says that maybe since the immune system recognizes self versus non-self antigens
in the context of this interaction between the MHC molecules and the T cells, that maybe if there's a problem with the MHC molecule or a problem with the T cells or a problem with the way those two things interact with each other, maybe that's what causes autoimmune disease. Another theory proposes that maybe the bone marrow and the thymus aren't doing a good job of screening for those potentially self-reactive cells. Remember we said that the B cells mature in the bone marrow, the T cells mature in the thymus, and the bone marrow and the thymus are supposed to be screening for self-reactive cells, and if it finds any, it's supposed to get rid of them. So if the bone marrow or the thymus are not doing a good job of screening, then maybe it's letting self-reactive cells slip through into the circulation. It's also possible that maybe it's a problem with the suppressor T cells. Remember, one of the jobs of the suppressor or regulatory T is they're supposed to suppress the activity of self-reactive white blood cells. So if the suppressor or regulatory T cell is not doing its job, that could also be a cause of autoimmune disease. Then we have a theory called the antigenic mimicry theory. So what does it mean to mimic something? It means to copy, right? So according to the antigenic mimicry theory, maybe there are foreign antigens out there that look so much like a normal self-antigen that if you get infected with a pathogen that has one of those antigens on it, and you make antibodies against that antigen, those antibodies might then turn around and attack your normal self-antigens, and that would be an autoimmune disease. Now, there does seem to be some support for that theory because we think that's how rheumatic heart disease and certain kinds of glomerulonephritis might occur. So do you remember in micro talking about a bacteria called Group A beta hemolytic streptococcus? Okay, so Group A beta hemolytic streptococcus has an antigen on it that looks a lot like the normal self-antigens in your heart and your kidney tissue. So if you get infected with Group A beta hemolytic streptococcus and you make antibodies against that organism, those antibodies could then turn around and attack the antigens on your heart tissue and cause rheumatic heart disease, or attack the antigens on your kidney tissue and cause glomerulonephritis. So that's the reason why if you have a sore throat and you go to your doctor, he's probably not going to be all that excited about it unless he thinks you might have a strep throat. And if he thinks you might have strep throat, he's going to want to culture it and see if it's Group A beta hemolytic streptococcus. Because if it is, then he's going to want to put you on antibiotics and kill that organism before your immune system has a chance to make a lot of antibodies against it. Because if you make a bunch of antibodies, you could be at risk for rheumatic heart disease and glomerulonephritis. Does that make sense? The last theory that I'm going to mention is called the release of sequestered antigens. So what does the word sequestered mean? It means to hide away or to isolate, right? Have you heard of some of these high-profile court cases where they sequester the jury? They hide them away or isolate them so they can't be influenced by what they read in the newspaper or the TV or things like that. Well, anyway, the theory of the release of sequestered antigens is based on the assumption that your immune system learns which antigens belong to you and which do not at some point during embryonic or fetal life. And if there are some self-antigens that are sequestered or hidden away from the immune system during that time, then the immune system never has a chance to learn that those antigens actually belong to you. at some later point in time, if tissue gets damaged and those previously sequestered antigens are now exposed to the immune system never learned that those belong to you, is going to think that those antigens are foreign, and it's going to start attacking them. And then you have autoimmune damage. Does that make sense? Now, we don't really know which, if any, of those theories are correct. On the other hand, maybe they're all correct, right? Because there are so many different kinds of autoimmune diseases out there that it's entirely possible that there is more than one way autoimmune diseases get started. But even though we don't know the exact mechanism through which autoimmune diseases develop, we have identified some factors that seem to predispose to it. There could be some genetic factors that are involved here. We don't know the exact genes that are involved for every kind of autoimmune disease, but we do notice that a lot of autoimmune diseases seem to run in families. And we also notice that a lot of autoimmune diseases occur more often in people with certain MHC or HLA genotypes. So that does sort of suggest that there are some genetic factors involved. But it seems that there also needs to be some sort of trigger event to get the process started, because we do know that not everyone who has a genetic predisposition to get an autoimmune disease will actually develop one. Now, what the triggers are, we aren't really sure. Maybe it's a virus or some other kind of pathogen that damages a self-antigen, so it isn't able to be recognized anymore. Or maybe it's a injury that exposes a previously sequestered antigen to the immune system. Maybe it's exposure to some sort of chemical substance that then binds to a self-antigen so it doesn't look the same anymore and is not recognized. All of those things could potentially be triggers that get the autoimmune process going in people who have that genetic predisposition. Finally, gender seems somehow involved in predisposing to autoimmune disease, because we do notice that a lot of autoimmune diseases occur more often in women. So the thought is that maybe estrogen plays a role in the development. Now, there is some evidence that suggests that estrogen may stimulate the immune system and androgens may suppress it, because we do notice that women tend to get more autoimmune diseases while men tend to get more infections. So that does seem to support that idea. We also notice that for autoimmune diseases, a lot of times they are either diagnosed or they get worse during times when there is a lot of hormonal shifting going on in the body. So we tend to see a lot of diagnoses during puberty, as well as in women during pregnancy. So that also suggests that hormones may have something to do with it. Now, a lot of autoimmune diseases do occur in cycles of what we call remissions and exacerbations, or flares. All that means is the symptoms in an autoimmune disease are not always the same level of intensity. Sometimes the symptoms are worse, sometimes the symptoms are improved. When the symptoms get worse, we call it an exacerbation or a flare. When the symptoms tend to improve, we call it a remission. So our goal with these chronic long-term autoimmune diseases is to minimize the exacerbations, to get patients into remission, and to keep them there as long as we can. Now, there are a lot of different kinds of autoimmune diseases, but we can usually break them down into two types. Some are what we call organ-specific, meaning the damage is limited to one particular body organ or body tissue. Examples of organ-specific autoimmune diseases would be type 1 diabetes, where the attack is limited to the beta cells in the endocrine pancreas. There are a lot of thyroid diseases that are autoimmune in origin, and something like ulcerative colitis, where the immune system's attacking the intestines. Okay, those are organ-specific disorders. Other autoimmune diseases are more systemic, meaning they can affect tissues in many different body systems, like rheumatoid arthritis and lupus tend to focus on connective tissue or tissues with collagen. And there's connective tissue and there's collagen all over your body in many body systems. So there are some diseases that you see symptoms in several body systems. Assessment findings are, of course, going to vary from one autoimmune disease to the next, because the symptoms that you see are going to depend on which tissues or body organs are being attacked, how severe the attack is, and on whether the attack is more acute or chronic. Now, there are a few autoimmune diseases that are acute and go away, but the majority of autoimmune diseases occur in those cycles of remissions and exacerbations that we talked about, and they're more of a chronic, long-term thing that never really goes away. But even though the symptoms of autoimmune diseases can be very different from each other, the diagnostic findings are actually quite similar. There are two primary groups of tests that we run. We look for inflammatory markers and autoantibodies. Inflammatory markers are just markers that we find in the blood in the presence of inflammation. And since we usually define inflammation as the tissue's response to injury, when there are elevated levels of inflammatory markers, that tells us that there is injury somewhere in the body. It doesn't tell us where that injury is, but we do know that injury is present. And since autoimmune diseases are diseases where we're attacking body tissues, of course there's injury, right? And so we do expect inflammatory markers to be elevated. C-reactive protein, or CRP, is the first inflammatory marker I want to mention. CRP is a substance that's produced primarily in the liver, and it seems to play a role in regulating the release of cytokines and therefore helping to regulate inflammation. Fibrinogen is another protein that we tend to find in increased amounts during inflammation. And maybe you're wondering, wait a minute, I thought fibrinogen was a clotting factor. Well, you're right, it is. But it also seems to be produced in higher amounts when there's inflammation present. And in that situation, it seems to help locate pathogens so they can be destroyed. ESR, or erythrocyte sedimentation rate, is another test that we run to see if there's inflammation in the body. The way this test works is we draw blood and we spin that blood specimen in a centrifuge, and we time how long it takes the cells to drop to the bottom and the fluid to rise to the top. So do you understand the name now? We are timing the rate at which the red blood cells, or erythrocytes, sediment to the bottom of the specimen. When there's inflammation present, the red blood cells seem to be heavier because the other inflammatory markers that we talked about, things like C-reactive protein and fibrinogen, tend to stick themselves to red blood cells. And now that the red blood cells have all these things sticking to them, they're heavier than they usually are. So when we put them in a centrifuge, since they're heavier, they're going to drop to the bottom faster, right? So the rate at which those cells are going to sediment increases. So ESR is increased in the presence of inflammation. So the point I'm trying to make about these inflammatory markers is these are all things that are increased in the presence of inflammation. And in autoimmune diseases, there's almost always inflammation present because tissue has been injured. So in Adult Health 1, 2, and 3, when you study about different autoimmune diseases, they're going to give you all these lists of lab tests that are going to be abnormal. And you don't need to, try and memorize for each separate autoimmune disease. Is the CRP up or is it normal in this disease? What about ESR? Is that elevated in this disease or not? You don't have to remember that separately for each autoimmune disease. All you have to do is ask yourself, is there inflammation present in this disease? And if the answer is yes, then you know that these inflammatory markers are going to be increased. Does that make sense? So those are 3 of the more common inflammatory markers that we look at. There are more, but those are the only 3 I'm going to expect you to recognize for the test. Okay? All right, so let's talk about autoantibodies now. What do you think an autoantibody is? Well, auto means self, right? So an autoantibody is an antibody that is attacking self-antigens. And you would expect to find autoantibodies present in autoimmune diseases, right? Because probably in an autoimmune disease, the thing that's attacking the self-antigens is an antibody, right? So I've given you some examples of autoantibodies that we find in some of the more common autoimmune diseases. Not every autoimmune disease will test positive for the same autoantibody. Some autoimmune diseases only cause an elevation in one of these. Some might include elevations in several of these. There are other autoantibodies that I didn't list here, and there are probably autoantibodies that we don't even know about yet. Okay, but the point being, if we think somebody might have an autoimmune disease, one of the ways to double check that is to see if they have any autoantibodies in their blood. Now, if you find autoantibodies, that doesn't necessarily tell you which autoimmune disease a person has, because some of these autoantibodies can appear in more than one autoimmune disease. But these are the ones that we more commonly look at, and these are the only ones that I'll expect you to recognize on the test. As far as interventions for autoimmune diseases go, we usually intervene on 2 levels. The first one is we try to stop the underlying autoimmune attack on self-tissues. That's usually going to involve somehow suppressing the immune system so it's not attacking self anymore. That may involve immunosuppressive drugs, or it may involve something like plasmapheresis, which you remember we talked about previously. But that's the thing that we do to try and stop the disease process where the immune system's attacking self. The other level of intervention would involve trying to treat and relieve the symptoms. That's going to depend on which autoimmune disease we're talking about. If we're talking about type 1 diabetes, to treat the symptoms of type 1 diabetes, that would probably require us to give insulin injections. If the autoimmune disease is rheumatoid arthritis and people have painful swollen joints, then treating the symptoms is probably going to involve giving some kind of pain medication or anti-inflammatory medication to take down the swelling and relieve the pain in the joints. So we're trying to stop the autoimmune attack, and then we're trying to treat the symptoms. Does that make sense? So I wanted to pick one specific autoimmune disease to look at in a little bit more detail. So I chose SLE, which stands for systemic lupus erythematosus, because this is one of the more common ones. So in lupus, what happens is the immune system makes antibodies against a variety of self-antigens. But one of the primary autoantibodies that gets made is ANA, or anti-nuclear antibody. And if we look back at our previous slide, you'll see that anti-nuclear antibody is at the top of our autoantibody list. So anti-nuclear antibodies are just what they sound like. They're antibodies that attack antigens that are in the nucleus. as near as we can figure out, the process goes something like this. Cells somewhere in the body are damaged, and the DNA in the nucleus is exposed to the immune system. And for some reason, through mechanisms that we don't really know, the immune system decides to make antibodies against the antigens in that DNA. So now we have anti-nuclear antibodies. Once those antibodies are made, they're going to then bind to antigen on the DNA of any other body cells that are injured, and they're going to form these little antigen-antibody complexes that you see there near the top of that diagram. Now, it's not the formation of the antigen-antibody complex itself that causes the problems in lupus. What happens is those antigen-antibody complexes then get deposited in tissue, and when they deposit in tissue, that activates the complement system. And do you remember what that one word is that you're supposed to think of whenever you think of the complement system? It's inflammation, right? So those antigen-antibody complexes deposit in tissue, activate the complement system, and generate inflammation. And it's the inflammation that causes all the symptoms that we see in lupus. So remember I said that in lupus, a lot of autoantibodies get made, and ANA is just one of the more prominent ones. We do see autoantibodies getting made against a lot of our blood cells, like red blood cells and platelets and so forth. But also remember that a lot of the symptoms in lupus are due to the activation of the complement system, right? Those antigen-antibody complexes depositing in tissue and activating the complement system. And we do find that the antigen-antibody complexes tend to deposit in tissues that have a lot of collagen in it. And you remember that there's collagen in many body systems, and that explains why you see symptoms in many body systems. Since we said that the antigen-antibody complexes like to deposit in tissues with a lot of collagen, we expect to see lots of problems with the skin, right? Because the skin has a lot of collagen. We see bruising, we see rashes. Here's a classic symptom of lupus, what we call the butterfly or malar rash. We call it butterfly because it kind of has that butterfly shape on the face where the wings are on the cheeks and then the body of the butterfly goes over the bridge of the nose. Here's another view of the malar rash, and the skin manifestations of lupus tend to be worsened by sun exposure. And as a matter of fact, exacerbations are frequently triggered by sun exposure, so we like to keep our lupus patients out of the sun as much as possible. But remember we said that the problems tend to occur most often in places where there's a lot of collagen, and there's collagen in a lot of our body systems. So in addition to the skin, we're going to see symptoms in the joints with like a lupus arthritis. We may see problems with the kidney, inflammation, maybe renal failure, also changes in the lungs, in the heart, in the eyes, in the GI tract, all over the place. And it doesn't affect all of these systems in every patient. And that's what makes lupus more challenging to diagnose, because you could have 10 different people with lupus and they could present 10 different ways just depending on which of the body systems are most affected. A lot of people think of lupus as, quote, the great imitator, because, if you have somebody whose kidneys are infected, we're going to be testing them for a lot of kidney diseases instead of for lupus. Or if they have joints that are affected, we're going to be checking them for different kinds of arthritis and not for lupus. So it does make lupus very difficult to diagnose. There is no one specific diagnostic test that you can run that says definitively, yes, this is lupus. It's more of a trial and error kind of thing. And I think the general public thinks that the diagnosis of lupus is a lot more concrete, more black and white than it really is. They'd probably be totally horrified if they knew that this is more of a, well, we ruled this out and we ruled that out and we know it's not this, so it must be lupus kind of thing. That's the reason why it takes some patients years to get an official diagnosis of lupus, and it's very frustrating for people. So if you remember these diagnostic tests we talked about earlier, the inflammatory markers really just tell us that there is inflammation present, but it doesn't tell us what's causing it. The autoantibodies tell us, yes, this is probably an autoimmune disease, but it doesn't tell us which one. And so diagnosis is challenging because there isn't one specific test that can prove definitively that this is lupus. Diagnosis is usually based on, the symptoms that are common in lupus. We've done tests to rule out all the other things that it could be. It occurs in cycles of remissions and exacerbations. Inflammatory markers are elevated. There are some autoantibodies present. Okay, now we're going to diagnose you with lupus. As for interventions for lupus, here you can see us addressing the two levels that we look at when treating autoimmune diseases. The immunomodulators are there to try and modulate or change immune activity. The goal is to suppress the immune system attack on self-antigens. The other level is treating the symptoms. And to relieve the inflammation that the autoimmune attack has caused, we're going to give anti-inflammatory drugs. So we have two types of anti-inflammatory drugs. We have corticosteroids, and we have non-steroidal anti-inflammatory drugs like Motrin or ibuprofen or aspirin. Now, the corticosteroids are the more powerful anti-inflammatory drug, but they do cause a lot of side effects. They are actually like synthetic forms of cortisol, which your adrenal cortex makes, but in large amounts, they do have a lot of side effects, and we will talk about what those side effects are later in the quarter. But for now, I want you to know that corticosteroids are powerful anti-inflammatory drugs, but they do have a lot of side effects. The non-steroidal anti-inflammatory drugs have way fewer side effects, but they aren't as powerful. So they would probably be enough to maybe relieve the arthritis pain and so forth, but aren't going to be enough to halt like damage to the kidneys from inflammation and that kind of thing. So we will use the NSAIDs and then add the corticosteroids if necessary. All right. The last of the 4 immune system functions that we're going to talk about is inflammation, which you remember we said is part of your immune system's process for defending you against harmful agents. And earlier we defined inflammation as the tissue's response to injury. Now, before we go any further, I want to clarify the difference between inflammation and infection, because a lot of people get them mixed up. What's the difference between those two? Well, remember we said inflammation is the tissue's response to injury. And maybe that injury is caused by an infection, but there are a whole bunch of other things that could cause injury to tissues besides an infection, right? For example, if I had a knife and I cut you, okay, the tissue is injured and there's not necessarily infection present, right? If you get burned or you get frostbite, or if you spill an acid on yourself, or there's no blood flow going to your fingers, okay, all of those things can cause injury to tissue without there necessarily being any infection present. In order to qualify as infection, there has to be some sort of pathogen present, okay? So, to recap the difference, inflammation is what happens when the tissue gets injured. If the tissue is injured because of the presence of pathogens, that's infection. But there are a whole bunch of other things that can injure tissue besides just infection. Does that make sense? Now, when we put the suffix itis on the end of something, like appendicitis or pericarditis, okay, what does itis mean? It means inflammation of, right? But I think sometimes people fall into a little sloppy thinking, and when they hear itis, they automatically assume it means there's an infection present. Okay, so I just want to remind you, itis means inflammation, and inflammation can be caused by infection, but is not always caused by infection. All right? Now, the immune system has a purpose for generating inflammation. Inflammation is intended to limit the spread of a harmful agent, to help neutralize or destroy that harmful agent, and to try and prepare the damaged tissue for repair. Those are all really great things, right? But most people don't like inflammation. Why is that? Because it doesn't feel good, right? Do you remember the cardinal signs of inflammation? Heat, redness, swelling, pain, and loss of function. Of course, we hope the loss of function is only temporary, but sometimes inflammation becomes chronic, and that loss of function can become much more permanent. But if you see what the symptoms of inflammation are, and if you think back to that picture we looked at of those toes that were so inflamed, they look so painful, it's perfectly understandable why people think of inflammation as a bad thing. But we're going to talk more about what happens during the inflammatory response so that we can see how it accomplishes those useful purposes we said it has, but also why it causes these unpleasant symptoms. So, since we defined inflammation as the tissue's response to injury, the first thing that has to happen is that tissue has to get injured, right? When tissue gets injured, that triggers the mast cells and the basophils to degranulate and release a whole bunch of chemical mediators of inflammation. So you remember what a basophil is, right? It's a granulocyte, and the little granules inside the basophils have all kinds of chemical mediators of inflammation inside. A mast cell is very similar to a basophil. In fact, a mast cell is basically just a basophil that has moved into the tissues. And the granules inside the mast cells and the basophils have all of those chemical mediators of inflammation in them, like histamine and prostaglandins and leukotrienes and bradykinin, certain kinds of cytokines, and so forth. And you don't have to memorize this slide, okay? But I'm just showing it to you so that you can get an idea of how many different kinds of chemical mediators there are. You know, people always just think of histamine as a chemical mediator of inflammation, but there are a whole bunch of other ones as well. In response to the release of those chemical mediators of inflammation, we have three types of responses. We have a vascular response, a cellular response, and an acute phase response. And we're going to say a few words about each of those three. Starting with the vascular response. Vascular means blood vessel. So we've got a couple of things that happen in the blood vessels in response to the release of these chemical mediators. The first thing that happens is you get vasodilation, right? And the benefit of vasodilation is it brings more blood to the area, and that blood brings it with it more oxygen, more fuel, more antibodies to fight infection, and all of those good things. But which of those cardinal signs of inflammation does that vasodilation cause? It's going to make it more red, and it's going to make it warmer, right? The more blood you have there, the warmer it is. The second thing that happens during the vascular response is that those blood vessels, those capillaries, get more permeable, meaning they get kind of leaky, and fluid's going to leak out of those blood vessels into the tissues. And the benefit of that is As that fluid leaks into the tissues, again, it's bringing with it nutrients and antibodies and all of those things that are needed to fight infection and to help the tissue start to be repaired. But which of those cardinal signs of inflammation is the leaking of fluid into the damaged tissue? Which of those symptoms is it going to cause? There's going to be swelling or edema, pain. When you have swelling, there's usually pain that goes along with it, and perhaps some loss of function, right? Because sometimes when body parts get swollen, they don't work as well. Have you ever, jammed your finger and ended up with a sprained finger joint? Your finger gets all swollen, right? When your finger's all swollen like that, can you bend it? No. Okay, so you've lost some function in that finger, which hopefully will only be temporary. When the swelling goes down, the function should come back. But the point being that part of the vascular response, you can see how all of those cardinal signs of inflammation are going to occur. Now you can actually see an example of that increased capillary permeability or the fluid leaking out of the capillaries if you look in an open wound. A lot of open wounds generate what we call exudate, right? Exudate just means there's a lot of fluid collecting in that wound. Sometimes the exudate is serous, meaning it's a clear, light yellowish thing. That's, basically the serum part of the blood without the cells in it. Or the exudate might be what we call serosanguinous. The sero part being like serous, and the sanguinous part being like blood. It's just bleeding, right? So have you ever seen fluid leaking from a wound that's kind of like watery blood, or it's like a fluid that's kind of pink? Okay, that's serosanguinous. But the exudate can also be what we call purulent, which means what? It's pus, right? That means it's kind of infected and there are dead white blood cells in there making it look pussy. Okay? So when you look at an open wound and you see this kind of exudate, most people are like, ew, gross, right? But remember that most of the time that exudate is actually good because it's fluid that's leaking into the injured tissue that's bringing with it nutrients and oxygen and antibodies to prevent infection, to promote healing. It also does a couple of other good things. If it's a dirty wound, then that fluid that leaks into the wound can kind of help clean it out, right? Hopefully flushing out any dirt that you might have missed when you washed the wound or whatever. So it can kind of dilute out any irritants or any toxic substances that might have contaminated the wound. Plus, when the fluid leaks out of blood vessels into the tissue, that means there's less blood flowing through that area and going on to other parts of the body. And the good thing about that is if that wound is contaminated, then we've kind of got a little bit more stagnant blood flow through that area. So the blood is less likely to pick up the contaminants and carry it to other parts of the body where it can cause problems in some other parts of the body. So you can see that all the things that happen as a result of the vascular response have beneficial effects. Now, you may not be able to see the exudate in wounds that are not open, but a similar kind of thing is happening when tissues in other parts of the body get damaged. The second thing that happens in response to the release of the chemical mediators of inflammation is what we call a cellular response. And the cells that we're talking about here are your white blood cells. So your phagocytic cells are going to migrate over to the area of the injury. The neutrophils are going to get there first, followed by the monocyte macrophages, and they're going to phagocytize and get rid of any pathogens that might have contaminated the injury, any dead tissue that's present so it can get it ready for repair. And then, if needed, it can signal adaptive immunity, right? Remember, those phagocytic cells can serve as antigen-presenting cells that can, show T cells any foreign antigens that it found, and that gets adaptive immunity going to make sure that that injury does not get infected. The third thing that happens in response to the release of the chemical mediators of inflammation is what we call the acute phase response. And this refers to some of the more systemic effects of inflammation. The other two responses were more local to the area of the injury. This describes some things that happen more systemically, like fever. Right? We've already mentioned how fever can be beneficial in some circumstances. Remember, bacteria can't survive in the higher temperature, white blood cells become more active, and those kinds of things. So the acute phase responses, fever generation, can actually have some beneficial effects. Another thing that happens as part of the acute phase response is leukocytosis, which refers to an increase in the number of white blood cells. Now, here we're talking not just the white blood cells that you already have migrating over to the area of the injury, but we're talking about an actual increase in the number of white blood cells in your body. Now, in the clinical setting, whenever you have a patient that is running a fever and has an increase in their white blood cell count, what do we almost always think? We almost always think they have an infection, right? But remember, these are things that we see in inflammation, and we already said that inflammation is not always caused by infection, right? So let's think of some examples where you might have a fever and an elevated white count, and there's not infection present. Okay, so what if you have a patient who had major back surgery at 6 in the morning, and now it's 5 o'clock in the afternoon, and you're taking care of this patient post-operatively, and you look at their vital signs and you look at their latest CBC, and you see that the temperature and the white blood cell count is a little bit higher than it was before the surgery. What are you going to think? Okay, well, your immediate reaction is, oh, maybe they have an infection, right? But it's probably a little early to actually be seeing signs of a wound infection. What could explain this if it's not an infection? Okay, remember, fever and elevated white count are part of inflammation. Inflammation is the tissue's response to injury. Has this patient been injured? Yes, we just cut a big incision in their back. And then we stuck our hands in there and fiddled around, right? So, yes, there's going to probably be some inflammation. And so we don't necessarily jump to the conclusion that there's an infection. Although it is possible, since we did cause a break in the skin, that there might be infection. How are we going to tell whether there's infection or not? Okay, probably the easiest thing to do would be to just monitor the trends, right? If this patient did get an infection, the fever and the white count are going to continue to get higher and higher. If the fever and the increased white count was just a response to the surgical incision, that will only go up to a certain point, and then we'll start heading back down. Right? Of course, you can also look for other signs of infection, like maybe pus formation, or you can do a wound culture, right? Those can help you figure out whether it's actually infection or just inflammation. All right, a second example. Let's say you work in the cardiac care unit and you're taking care of a patient who was admitted for a heart attack the previous evening. Okay, and you check his vital signs and his latest labs, and you see that his temperature and his white count are higher than they were when he was admitted. What are you going to think? Okay, so this patient had a heart attack. Is it likely that he got an infection in the day that he's been in the hospital? Probably not. Does he have injured tissue? Yes, where? His heart muscle, right? Some of his heart muscle died, some of it got injured, so there is going to be some inflammation. And the fever and the elevated white count are probably due to that. Now, admittedly, the fever and the increase in white blood cell count is probably not going to be great, but you will probably see it. So, if you know to expect it, then you aren't going to necessarily jump to the conclusion that this patient has gotten an infection. All right. Also part of the acute phase response, here is where we're going to see an increase in those inflammatory markers that we talked about earlier, right? And we also might see varying degrees of skeletal muscle catabolism. Okay, what does catabolism mean? It means we're breaking down protein, right? So skeletal muscle catabolism means we're breaking down our skeletal muscle. Now, you might wonder, what earthly reason could there be to start breaking down skeletal muscle, right? Okay, well, if you think about it, what is your skeletal muscle made out of? Protein, right? And when you break down protein, what do you get? Amino acids, right? And these are amino acids that we could use to make antibodies, or we could use to repair the damaged tissue. So if you think about it, there is a logical reason why you might want to break down your skeletal muscle. But, your body is usually pretty good at only mobilizing the degree of inflammation that's useful in a particular situation. If you were to get a mosquito bite, you might have the redness and the swelling and maybe a little pain or itching, but you're probably not going to run a fever. You're probably not going to start breaking down your skeletal muscle because that's not useful in this situation, right? On the other hand, if you had like an appendicitis, now you might be running a fever and you might start breaking down your skeletal muscle. So do you see what I mean when I say the body is usually pretty good at only mobilizing the degree of inflammation that's useful in a particular situation? That's not to say, though, that inflammation never gets out of control, right? Sometimes inflammation can become very severe, or it might become recurrent or persistent, like it never goes away. And in those cases, yes, it can be harmful. For example, a lot of times, remember when there's chronic irritation or inflammation, we said that the cells might try and adapt to that by undergoing metaplasia, right? They change from one cell type to another cell type that's better able to stand that chronic inflammation. So a lot of times when there's chronic inflammation in a tissue, we see scar tissue form. You might see it in the joints of somebody with a chronic inflammatory disease like rheumatoid arthritis. Do you see how the scar tissue has pulled this person's joints into a position that nobody's joints should ever be able to go into, right? So there's not only deformity, but there's loss of function there too. Here's another view of somebody with a bunch of scar tissue in the hands causing deformity. If it was in a different part of the body, like let's say there was a lot of chronic inflammation in the kidneys and scar tissue formed in the kidneys, we're still going to lose functionality there, right? Because can scar tissue filter blood and make urine the way kidney tissue can? No. Okay, so you see that if inflammation does get out of control, it can become detrimental. So if we look again at the purpose of inflammation, I hope you can now see how it does accomplish these things. But again, we know that under certain circumstances, inflammation can get out of control, and that can have some very negative effects. So next I want to talk about one example of what can happen when inflammation gets out of control or inflammation is inappropriate. Hypersensitivity disorders. This is what we call it when a person's immune system reacts to an antigen that most people would not react to. It's not a normal immune response, it's not appropriate, and it's usually excessive to the point where it can damage the host tissue. Now, a lot of people use the terms hypersensitivity and allergy interchangeably, but they're actually not exactly the same thing. An allergy is a specific type of hypersensitivity disorder in which the person's immune system reacts to an antigen in the environment that doesn't bother most people. Like, most people aren't bothered by cat dander. If you are and your immune system reacts to cat dander, you have an allergy. Okay? But there are other kinds of hypersensitivity disorders. Like, in some people, their immune system reacts to self-antigens. Most people are not bothered by self-antigens, right? If your immune system reacts to a self-antigen, what do we call that? That's an autoimmune disease. So autoimmune diseases are another type of hypersensitivity disorder. So do you see what I mean? Hypersensitivity disorder is like a broad umbrella term that includes anything that causes your immune system to react to something that most people would not react to. An allergy and an autoimmune disease are two specific examples of hypersensitivity disorder. Does that make sense? There are two predisposing factors to hypersensitivity disorders: genetic predisposition and exposure to the triggering antigen. It seems that both of these need to be present. If one or the other is missing, a person should not develop a hypersensitivity disorder. For example, let's say you have somebody who has a genetic predisposition to be allergic to cat dander, but they're never ever around a cat. Is that person going to have a hypersensitivity disorder? No. Okay, what if you have somebody who's around cats all the time, but they don't have that genetic predisposition to be allergic? Are they going to have a hypersensitivity reaction? No. So you need to have both of them. And as far as how you're exposed to the triggering antigen, that could be something that you inhale, like pollen, something that you ingest, like peanuts, something that you inject, like maybe penicillin, or something that you come in skin contact with, like latex or poison ivy or something like that. There are 4 categories of hypersensitivity disorders: type 1, type 2, type 3, and type 4. Each of these types of hypersensitivities are characterized by a specific pathological event. For example, types 1, 2, and 3 are mediated by antibodies, so, that's through your B cells, right? Because your B cells make antibodies. Type 4 is the only one that seems to be mediated through the T cells. So each type has a specific pathological event associated with it. Now, within each of these 4 types, there are many different syndromes, and the symptoms of the syndromes within each type can be very different from each other, but the underlying pathology for all of those syndromes within that type is the same. Now, that seems really weird, so let me say it again, okay? There are many different syndromes within each of these 4 types of hypersensitivity disorders. And the symptoms of all the syndromes within that same type can be very different from each other. But the underlying pathological event in those syndromes is the same for all syndromes within that type. Now, that may seem totally impossible, but let's talk about type 1, and I think you'll start to see what I mean. Okay, type 1, also known as IgE-mediated hypersensitivity disorders. Remember last class period when we talked about all the different kinds of antibodies? we said that IgE antibody was the one that's associated with allergic reactions. So that's what we're talking about right now. Almost everything that we think of as a, quote, allergy is a type 1 hypersensitivity disorder. For that reason, when we talk about the antigens in a type 1 reaction, we sometimes call them allergens because they're the antigens that cause the allergies. Okay, so the process goes something like this. Somebody is exposed to an allergen like pollen or cat dander or peanuts, okay? When they're exposed to that triggering antigen, at some point, that person's B cells decide to start making IgE antibodies against that allergen. Sometimes it's with the first exposure to the allergen. Sometimes it's with the 10th exposure. We don't really know why some people's B cells decide to start making IgE antibodies against that allergen, and we don't know why some people make it after the first exposure, some people don't make it until the 10th exposure, some people might not make it until the 50th exposure. But at some point in time, that person's B cells decide to start making IgE antibodies against that allergen, and those IgE antibodies then go and stick themselves to the cell membranes of your mast cells and your basophils. Now, you remember your mast cells and your basophils are the cells that have the little granules in them that contain all those chemical mediators of inflammation, right? And when those IgE antibodies go and stick themselves to the cell membranes of the mast cells and basophils, that person is now considered sensitized to that allergen, because once they have the IgE antibodies on the cell membranes of their mast cells and basophils, the next time they get exposed to that allergen, it's going to bind to the IgE antibodies on the mast cells and the basophils and cause them to degranulate. And the mast cells and the basophils are going to release all their chemical mediators of inflammation, and those chemical mediators of inflammation are going to cause all the symptoms of the allergies that the person experiences. All right, so let's run through that quickly one more time. Person's exposed to an allergen. Their B cells decide to make IgE antibodies. Those IgE antibodies stick themselves to the cell membranes of the mast cells and the basophils, and now that person is sensitized to that allergen. The next time and every successive time that that patient is exposed to that allergen, the allergen is going to bind to the IgE antibodies on the mast cells and basophils, cause them to degranulate and release all their chemical mediators of inflammation, and that's going to cause the symptoms of that allergy. All right, I have 2 points I want to make before we start looking at examples of type 1 disorders. The first point is, can you see why until a person gets, quote, sensitized, they won't have any allergic reactions, right? Because if they don't have the IgE antibodies on the cell membranes of their mast cells or basophils yet, there won't be any way to trigger the mast cells and basophils to degranulate and release their chemical mediators of inflammation, right? So type 1 IgE-mediated disorders are only possible once those IgE antibodies are on the cell membrane of the mast cells and basophils. All right, the second point is this. Can you see why we can actually never stop monitoring our patients for allergic reactions to medications? Because remember, we said we don't really understand why or when people's B cells decide to start making IgE antibodies, right? We said sometimes people's B cells make them after the first exposure to a particular allergen. Sometimes they don't make it until the 10th exposure. Sometimes they don't make it till the 50th exposure. So just because somebody has had a drug like maybe penicillin, just because they've already had the drug and not had an allergic reaction, doesn't mean that they're not going to start having one now, right? I've known patients who've had maybe 2 complete courses of penicillin and been fine. And then one day their B cells say, I think I'll start making IgE antibodies against penicillin today. And after that, they start having allergic reactions every time they receive penicillin. So the bottom line is we can never actually stop monitoring our patients for allergic reactions. Does that make sense? Now, here are some examples of type 1 IgE-mediated hypersensitivity disorders. Allergic rhinitis, also known as hay fever. What are the symptoms of hay fever? Well, people get runny noses, they sneeze a lot, their eyes get red and itchy and watery. What are the symptoms of asthma? Well, people get airway constriction, right? They wheeze and they have shortness of breath. What about atopic dermatitis, also known as eczema? Well, people get itchy, scaly, crusty rashes, right? They're incredibly itchy. Urticaria, also known as hives. What do hives look like? They kind of look like you have mosquito bites all over your body, right? And those are also very itchy. Angioedema. Do you know what angioedema is? Angioedema is when people's tongue and lips and part of their face starts to swell. Here's another before and after picture of angioedema. Finally, we have anaphylaxis, which is probably the most severe of the type 1 disorders. What are the symptoms of anaphylaxis? Okay, well, the big thing we worry about is their blood pressure drops, right? They become hypotensive. Yes, they might have bronchoconstriction and some shortness of breath, but the primary thing we worry about is the drop in the blood pressure, because if it drops enough, they can go into shock. Have you heard the term anaphylactic shock? Yeah, people can die from anaphylactic shock. But the point I'm trying to make here is all of the disorders on this list are examples of type 1 IgE-mediated disorders. Their symptoms are way different from each other, as we noticed, but the underlying pathological event is the same. We have the IgE antibodies stuck on the mast cells and the basophils that are binding to the allergen and causing those mast cells and basophils to release all the chemical mediators of inflammation, which cause the symptoms that we talked about that each of these things cause. The reason why the symptoms are so different from each other is it depends on where in the body the mast cells and the basophils are degranulating. If they degranulate in your airways, you have asthma. If they degranulate in your nasal passages or your the mucous membranes in your eyes, then you're going to have allergic rhinitis. If they're degranulating in your skin, you're going to have eczema or hives. If they're degranulating system-wide, now we have anaphylaxis. You remember in these hypersensitivity disorders, we have inflammation that's generated. Part of the inflammatory response is people vasodilate. If you vasodilate their whole body, their blood pressure is going to drop. They're going to go into anaphylaxis. Does that make sense? So now can you understand what I meant when I said there are many different syndromes within each of the 4 types of hypersensitivity disorders, and the symptoms of those different syndromes might be way different from each other, but the underlying pathological event is the same, right? We said that the symptoms of hay fever and asthma and angioedema were way different from each other, but the underlying patho event was the same. It was the IgEs causing the mast cells and the basophils to degranulate. Does that make sense? All right. This slide just shows you some common medications we use to treat type 1 hypersensitivities. And if you think about it, it should make sense, right? Because we said this hypersensitivity disorder involves the release of a lot of chemical mediators of inflammation. So we're going to treat with anti-inflammatory medications. right? And some of those chemical mediators of inflammation are histamine, right? So antihistamines. Does that make sense? We also want to help patients identify what they're allergic to so maybe they can avoid those things. Here you see somebody's undergone skin testing where we're sticking little bits of the antigen under the skin to see which ones cause a reaction. Of course, some things that people are allergic to are kind of hard to avoid. If you are allergic to a tree, that's very common where you live. You can only avoid that if you move away. Many people are allergic to their pets and they don't want to get rid of their pets. And that's when we're going to resort more to the medications. All right, let's talk about type 2 hypersensitivity disorders. We sometimes call type 2 antibody-mediated or cytotoxic disorders. Okay, so antibody-mediated means antibodies are involved, but they're not the IgE antibodies like in type 1. In type 2, we're talking mostly IgG and IgM antibodies that get made against certain antigens, and when the antibodies bind to the antigens, that damages the cell that the antigen is on. So a transfusion reaction is a great example of a type 2 disorder. So this is somebody who has type A blood, which means they have antibodies against the B antigen. If you give them a transfusion of type B blood, the recipient's antibodies are going to attack the donor cells, and when the antibody binds to the antigen on the donor cells, that's going to destroy the donated cell. That's a type 2 disorder. Myasthenia gravis is another example of a type 2 disorder. What happens in myasthenia is antibodies get made against the acetylcholine receptors at the neuromuscular junction. So even though acetylcholine is being released, the antibodies have blocked and damaged the acetylcholine receptors, so the muscles never get the message that they're supposed to contract. So again, in a type 2 reaction, when the antibody binds to the antigen, that damage is what causes the symptoms of the type 2 disorder. What about the type 3 disorders? Type 3 is sometimes called immune complex mediated hypersensitivity disorder. An immune complex is just a fancy word for the antigen-antibody complexes we've been talking about. When the antigen and the antibody bind together, that's an immune complex. Okay, so since we're talking antigen-antibody complexes, obviously antibodies are involved here. But again, it's not the IgE antibodies like in type 1. It's the IgG and the IgM antibodies. Okay, so then you might wonder, well, what's the difference between the type 2 and the type 3 hypersensitivities since they both involve IgG and IgM? Well, the difference here is that in type 2, when the antibodies bind to the antigen, that interaction causes damage, and that's what causes the symptoms. In a type 3 reaction, the antibody binds to the antigen and makes an antigen-antibody complex. It's not the binding of the antigen to the antibody that does the damage and causes the problems. What happens is the antigen-antibody complexes that are made get deposited in tissue where they activate the complement system. And when you activate the complement system, what do you get? You get inflammation. So it's the inflammation that causes all the symptoms of a type 3 disorder. So do you see the differences between the two? In a type 2 disorder, it's the antigen-antibody interaction itself that causes problems. In a type 3, the antigen-antibody interaction doesn't cause that big of a problem, but when those antigen-antibody complexes deposit in tissue, they activate the complement system, you get inflammation. That's what causes all the symptoms of the disease. Now, does that scenario sound familiar to you? It should, because that's what we said happens in lupus, right? Lupus is a great example of a type 3 immune complex related hypersensitivity disorder. All right, type 4, also known as T-cell mediated hypersensitivity disorder. So this is where type 4 is different from type 1, 2, and 3. Because remember, type 1, 2, and 3 all involve antibodies. And type 4 involves T cells, not antibodies. Okay, so what happens in a type 4 reaction is T cells get sensitized to some particular antigen, and when you're exposed to that antigen, the T cells are going to attack, and that's what causes all the symptoms. A great example of a type 4 reaction is what happens when you touch poison ivy or poison oak. There's a substance in the leaves of those plants that the T cells can become sensitized to. And once those T cells are sensitized, anytime you touch those plants in the future, the T cells are going to react, and it's going to cause a dermatitis on the skin where you touch the plant. Other examples of type 4 reactions are things like type 1 diabetes, because we think it's actually sensitized T cells and not antibodies that are attacking the pancreatic cells in type 1 diabetes. Certain kinds of transplant rejections are also considered to be type 4 reactions. Now, obviously, you can't just look at a patient's symptoms and be able to tell whether the damage was done by an antibody or a sensitized T cell, right? So we just sort of have to rely on the people who wrote the textbooks that they're telling us the truth, whether this disease was caused by an antibody or a T cell, right? For that reason, on the test, I cannot describe a patient's symptoms to you and expect you to be able to tell me, is this a type 2 reaction? Is this a type 4 reaction? Because you wouldn't be able to tell just by observing the symptoms. The exception to that statement, though, is if I describe anything to you that sounds like a, quote, allergy, I expect you to know that that is a type 1 IgE-mediated hypersensitivity disorder, right? Because remember we said pretty much everything that we consider a, quote, allergy is a type 1 disorder. All right. Now, the last thing I want you to learn from this slide is that you notice in addition to dividing the hypersensitivity disorders into types 1, 2, 3, and 4, we can also divide them into immediate versus delayed hypersensitivity reactions, right? You will notice that the immediate reactions are the type 1, 2, and 3, and type 4 is the only one that's considered delayed. With types 1 and type 2, you're going to see a hypersensitivity reaction probably within 15 to 30 minutes after exposure to the triggering antigen, right? If you have somebody with asthma and they're allergic to cats and you throw them in a little closet with a cat, okay, probably within about 15 minutes, that person's going to start to wheeze, right? Type 3 reactions are probably going to peak around 6 hours after exposure to the trigger. And maybe you're thinking, well, 6 hours, that doesn't sound very immediate to me. Well, it is if you compare it to type 4 reactions, which are probably going to peak between 1 to 3 days after exposure to the trigger. Okay, if you think about it, if you've ever touched poison oak and poison ivy and broke out in a rash, you don't break out in a rash like 15 minutes after you touch it, right? It's usually like a day or two later before you develop that rash. So, type 1, 2, and 3, those are considered immediate hypersensitivity disorders. Type 4, considered delayed. All right, as far as interventions, it's mostly involved getting rid of the trigger and then treating the symptoms. We don't really know how to desensitize you once you've been sensitized, so we're trying to avoid the triggers and then we're treating the symptoms. All right. If you have questions, remember to submit them so that I can address them in class. I will see you then.